Okay, hello. We are Symphony Biosciences. I'm Negin, the CEO of Symphony Biosciences, where we orchestrate body's natural immune response to fight cancer using our innovative biomaterial. Our company is mostly focused on tackling solid cancer because those are the type of cancer in charge of majority of the cancer death. When you think about it, it's really interesting how our body is naturally designed to be able to clear the tumor. But currently, the way that these tumor cells are winning the war is actually by turning their enemies into their allies. By enemies, I mean the immune cells, and by allies, I mean another type of cells called regulatory T cells. That now not only they're going to touch the tumor cell, but also they're going to stop the killer T cell from being able to clear the tumor. So we want to reverse this whole procedure. And the idea here is that by planting our product called SymphNode beside the tumor bed, we are going to summon more immune cells to the tumor bed. As a result, creating a bigger, stronger army to fight the cancer, while at the same time overcoming the barriers that are created by the tumor microenvironment. Now, it's very important for me to mention here that this has to be done locally in order to avoid systemic side effects, but not any local injection such as simple injection would do the job, which is why we have engineered this biocompatible, biodegradable, highly porous material that serves these two purposes for us and acts as a local powerhouse for awakening our body's natural immune response. Now, this idea has been already preclinically validated in two different tumor models, one of which is triple negative breast cancer, which is actually our first choice to go to market with. Why? Because of its high incidence rate that annually about 40,000 women in the United States are dealing with this specific type of cancer. And because the lack of targeted therapies made the survival rate for this specific type of cancer is pretty low. Even FDA allows for histological improvement as an endpoint rather than long and tedious survival endpoints. Now, triple negative breast cancer is just a start for us. Considering all the other solid cancer that can be our next target, we could be looking at about a $4 billion market opportunity. Sorry about that. Now, back to our preclinical data, we've been able to extend the survival in the mice with this highly aggressive triple negative breast cancer by about 2x. But not only that, we've also been able to prevent the metastasis from happening and spreading all over the body. And that's the beauty of awakening and working with and training the natural immune system, because once you train it against the tumor in one spot, it can track down and trace the tumor wherever it goes. Now, patent-wise, this technology is patented at UCLA, and currently we have an exclusive option agreement with them in place. And financial-wise, we've raised about $400K as our pre-seed round and are seeking funding of about $2 million for our seed round to get us to our IND meeting. Our co-founder team at Symphony includes of myself, which this technology was the fruit of 5 years of my PhD studies at UCLA. Dr. Hassani as the biomaterial scientist of the group, Dr. Butte as the immunologist of the group, and great advisory board that help us with the business, regulatory, and clinical trials. With that, I'd like to close and thank you and be happy.
Thanks so much for the presentation. I was curious as to why you're going after TNBC. It's certainly known as a boneyard for drug development. I would encourage you to take a look at a lot of the data that's coming out of Chicago right now at ASCO and how people are treating it. Have you thought about maybe other types of breast cancer, whether it's hormone positive, hormone negative, that you could potentially look at, which are potentially, greater probability of success?
That's actually, we went after the hardest one because the most of other breast cancer have already pretty good survival rate because hormone therapy is working pretty well. They have this hormone receptor on them that makes them responsive to those type of therapies. Triple negative actually lacks those hormone receptors, which makes them irresponsible. So, not responsive to those kind of like therapies, which is actually the hardest to go after. And any improvement in this area is truly valuable. Also, I think the fact that the clinical trials are shorter for this specific type of cancer is kind of promising. And if the technology is already working in terms of when it's the toughest breast cancer, why switching to easier ones? I mean, you want to make a difference where it matters most, right?
Can you talk a little bit more about what SymphNode is and the mechanism of action of how
it's just a trailer, so you can't open up the technology. So this is just a schematic of a triple negative breast cancer that after the palpation of the mass, An interventional radiologist probably is going to take a biopsy of the tumor, and that would be the time that we are intervening. And so this is just like representing the highly processed structure of this biomaterial, that the first step for this biomaterial is to advertise itself for the body. So your body would be aware of such a thing, and more immune cells are going to start to come to our structure. And we have adjuvants to do that for us. After the recruitment of the immune cells, now we provide them with the required training that they need against the tumor. It's important to mention that many of the immune cells that are coming to our structure have already experienced the antigens on the tumor. They have already experienced those antigens. They have been there. Now you're just adding an extra step to activate them and turn them on. And after they get the required training, they leave their boot camp, go and kill the cancer. But I also mentioned that one of the major issues, also, like I should mention that this whole structure have been engineered so that the mechanical stiffness is pretty similar to what our immune cells are experiencing within our lymph node, which is why we'd like to think of our product as a synthetic lymph node. That's where the name of lymph node comes from. But I also mentioned that there is another major obstacle in the tumor environment of solid tumors, and that's the abundance of those regulatory T cells that stop the activated T cell from being able to clear the tumor, for which we have embedded the small molecule drugs within our structure that is released in a sustained manner currently over the period of 2 weeks at the current tuning to reverse that whole process and stop the Tregs or regulatory T cells from forming in that place.
Do you have histological evidence that there is more immune infiltration when you have?
Oh yeah, we have a ton of data in terms of how many. Sorry, these are just. That was for the melanoma one, and so yeah. So these are the data that shows this is the latest data. Yeah, here shows how many more CD8 positive T cells have been recruited to the tumor environment, and as a measure of whether they are recognizing the tumor or not, whether they're granzyme positive activated or not. These are just the differences between, and so the blank one that you're seeing is the control mice that receives nothing but PBS. The red one that you're seeing here is just plain vanilla scaffold, just a porous scaffold with no immune activating drug. And the last one is kind of like the full scaffold that shows how, and this is just how perfectly we are doing in terms of recruiting more immune cells, more activated immune cells, and also in terms of suppressing those regulatory T cells. As you can see in the untreated tumor, there are about 40-45% of those regulatory T cells that are stopping the killer T cell, while we have reduced that number to about 10-12%. I don't know if it answers your question. Sure.
What is your
sorry. I'm sorry, I didn't.
What does your team look like today, and any key hires?
Sorry, I didn't get the question.
Oh, what does your team look like today?
Oh, our team look like today? Our team, oh God. Okay. Okay. So myself, this technology was the fruit of my PhD studies, and my background has always been in biomedical engineering. I've done my bachelor, master, and PhD in this field, working with different types of biomaterials for different applications. CSO of our company is Dr. Hassani right here, who has years of expertise, 2 PhDs actually, one in polymer science, one in biomedical engineering. So no one, I think, knows material science better than him, at least no one I've met so far. And Dr. Butte, who's the immunologist of the group, he has spent more than 20 years of his lab studying the immune cells, how they work in different areas. And in terms of the advisors, we have Dr. Michael Jungben, many of you already know him. Lawrence, who's helping us with the regulatory path. And Dr. Jennifer Baker, actually, she's one of the greatest breast surgeons at UCLA that on a weekly basis, she's actually visiting 2 patients with triple negative breast cancer. So she's been super helpful in terms of giving us advice how to design our clinical trials.
Negin, very interesting presentation. So if I understood it, you basically suppress Tregs locally to tissue, and then you're recruiting T cells. So the training set that you mentioned inside the biomaterial, is that a peptide? Or a
That's an
protein?
antigen.
It's an antigen.
That's an antigen that is known to activate, it's like general activation of the T cell. But like I said, because it's happening at the same time, the T cell is already experiencing the antigens on the tumor. So it's just the extra step of general activation that even, honestly, it surprised us to see how just addition of that one step was able to clear the tumor, because originally this product was meant to be just as a delivery vehicle for like a CAR T company, because that's also another thing I want to bring up, because one of like the paths that we see move forward for ourselves is to partnership with the CAR T companies, because
Right.
CAR T is working great for leukemia, but for the solid tumor, if you do the IV injection, very few of those CAR T will actually reach to the deep tissue and like tumors such as brain or breast.
Right.
Now, our first idea was to just load those CAR Ts within our scaffold. I mean, the schematic doesn't show up here,
Yeah,
but
no, I
to,
understand.
to just load those CAR Ts within this highly porous structure and plant it locally beside the solid tumor, giving them 100% chance of reaching to the tumor. But then, like, we met one of these great business people telling us that, oh, it's going to cost you, like, the process is going to be so costly and it's going to be really hard to ask the surgeon to load the cells in your scaffold and then at the time of surgery, put it in there. It's going to be complicated. Try it without the
Well,
cells.
yeah, I guess what I was getting at is you're putting this locally next to the tumor,
Mhm.
but if you have distant tumors, you probably could still respond to those. You don't have the suppression of the Tregs, but you could potentially even respond to those.
Yeah.
There doesn't need to be a local response. So technically, you could actually, if you have metastasized tumors, you could actually potentially respond to those other tumors as well, right?
Yeah, that's true.
And it's kind of a follow-up to that. I mean, I think you showed that you prevent metastases, but would you anticipate abscopal effects, or if you have one, shrinkage? Obviously, if you have 42 metastases, you have a challenge, unless you're seeing abscopal effects.
Okay.
I'm anticipating a yes in a slide right now.
Okay, so this is the situation that we have tried to kind of have two tumors at the same time. One lymph node is planted right beside the primary tumor on the left part, right here. And while we have injected the mice with another tumor, kind of representing the time that the patient shows up with metastasis already. So only an abscopal effect would be able to clear this situation. If the training that the T cell is getting in this side with the scaffold beside this, like inside this adjacent to this primary tumor, will form enough memory to be able to travel around and clear the second tumor. So yeah, I think we have the abscopal effect, because at the same time, when you're releasing the adjuvants, many of the immune cells are coming to this structure. DCs are gonna take like samples of these antigen, presenting them to the like immune cells, and those immune cells are going to afterwards take care of that second tumor that has metastases elsewhere. Sure.
Yeah, that's good.